Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as the program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in obstetrics and gynecology will answer your questions about all things menopause. Well, thank you so much for submitting your questions in advance, and the questions that you'll hear me asking the provider are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, let's go ahead and introduce our experts for the evening so we can kick off this discussion. So introducing Dr. Robin Fay with gynecology, Dr. Rebecca Jackson with obstetrics and gynecology, and Kara Pravdo with obstetrics and gynecology. Well, thank you all so much for joining us. Before we dive into the questions, I'll give each of you a minute or two to just say hello and provide a little background information about yourself, and then we'll kick off the evening. So, Dr. Fay, why don't we go ahead and start with you?
Thank you, Sarah. I'm a board-certified OBGYN, and over time, my practice has transitioned more to gynecology, menopause care, sexual health, pelvic pain, vulvar and vaginal dermatology. I'm a certified menopause practitioner, and I previously chaired the Consumer Edge Department of the Menopause Society. I'm also a certified sex counselor, and I truly believe everyone is entitled to a healthy, pain-free, and satisfying sex life. I teach residents, the nursing students here, and physician assistant students, and I really enjoy caring for women throughout all stages of life, from younger students, younger patients, to midlife and beyond. And I'm especially passionate about helping patients navigate through menopause, sexual health, and supporting cancer survivors as they work their way through sexual wellness.
Okay, well, thank you so much, and we're thrilled to have you here tonight. All right, next up, Dr. Jackson, how are you doing?
I'm great. Thanks, Sarah. I am an OBGYN at Jefferson in Center City. I practice full scope OB and GYN, but have a special focus on menopause and perimenopause. I've been here at Jefferson since 2013 and have been a certified menopause practitioner since 2014. And that's really where my passion lies.
All right, well, thank you. And last but not least, Kara, welcome.
Thank you. So I'm Kara Pravdo. I'm a nurse practitioner. I have been at Jefferson Einstein for 8 years. Started out doing OBGYN, and for the past over 5 years, I've been mostly family planning and then transitioning back into general GYN. I am definitely the newest to the menopause care on the panel. So I got certified a couple months ago when I realized how many of my friends and myself needed access to this care. And even people with a lot of resources and education were being told there's nothing they could do during perimenopause. So as soon as I realized that, hey, why did I graduate as a nurse practitioner in women's health and I don't know how to give good menopause care, and I don't think that the people around me were trained to in their programs either. So that motivated me to take those steps, and now I'm getting to expand and do more of this care. So I'm excited to be here.
Yeah, we're excited to have you. And with that, I say let's go ahead and dive into the questions because I know everyone has submitted a ton of questions to start with. So thank you. I think it's going to be a great conversation. So I will go ahead and ask the first question, and we'll just go through our submitted questions until we get to our live questions for the evening to kind of wrap us up. So to kick us off, Dr. Fay, we will start with you. Is it normal to still have menopause symptoms like hot flashes in your 60s?
Oh, yes. It's absolutely normal to still have menopausal symptoms in your 60s. Although the average age of menopause is around 51, the length of time women experience menopausal symptoms varies tremendously. So about 30 to 40% of women can actually continue to have hot flashes more than 10 years after menopause. And some women report having symptoms well into their 60s, even into their 70s. I know it's not fair, but it can happen. So when we look at studies, the medium or average age duration of hot flashes can be about 7 to 10 years, but for many women, it lasts longer than that. So symptoms are more likely to persist even if you have severe symptoms early. So if you went through menopause at a younger age, if you're more sensitive to estrogen changes, if you have certain risk factors, such as if you're a smoker, if you have anxiety, if you have lower body weight, or if you're of the Black race. Symptoms can persist, such as hot flashes, night sweats, sleep disturbances, vaginal dryness, brain fog, mood changes, joint aches, and even palpitations. The reassuring part of it is that we have options for treatment. So many women in their 60s can safely use vaginal estrogen, vaginal symptoms, and we also have effective non-hormonal treatments for many of the other symptoms. So the most important takeaway from all this is it's normal and your symptoms can be taken care of. So you don't have to live with them. So find someone to talk to.
Okay, a great takeaway. Thank you. All right, moving along to our next question here, Dr. Jackson. This one's for you. What are the most effective ways to manage sleep problems and insomnia during menopause?
I'm so glad you asked that. Sleep problems are very common in perimenopause and menopause, and they're important to address as lack of sleep can contribute to so many other symptoms. It's also important to think about what is causing the insomnia. It might be due to hormonal fluctuations and hot flashes, but it also could be from an underlying sleep disorder or underlying anxiety or depression. People with risk factors definitely should have a sleep study to rule out sleep apnea. As far as effective treatments, cognitive behavioral therapy for insomnia has been shown to be very effective. It has several components, some of which involve sleep hygiene education, talking about having a regular sleep schedule, a nightly routine, turning off electronics long before bedtime, stimulus control, using the bed and bedroom just for sleep, relaxation techniques, including breathing and mindfulness. They do sleep restriction therapy, which is to align the time spent in bed and the amount of time asleep. For instance, if you're spending 8 hours in your bed, but only asleep for 5 of them, set your bedtime and your wake time to equal 5 hours. And then cognitive restructuring to change our narrative about sleep, to make people less anxious about their sleep. There are several ways to get CBTI, which is how it's abbreviated, online. And there's also people who will do in-person counseling. Usually sessions will last for about 6 weeks. The other way to treat sleep problems in perimenopause and menopause is with hormone therapy. This is especially effective if night sweats are contributing to sleep problems. But even without vasomotor symptoms, micronized progesterone has been shown to improve sleep for patients, whether or not they're having hot flashes and night sweats. So those are the two most effective treatments for sleep problems in menopause would be CBTI and hormone therapy.
Okay, thank you. I know that's a hot topic, so appreciate you walking us through that. I think that's helpful. All right, Kara, we will turn to you now. Talking a little bit about symptoms. So, what are symptoms are common in perimenopause and menopause, and can you talk about how they can be relieved?
Yes, absolutely. Thank you. So there is some overlap in all of our questions. So you've heard about some of the issues that come up. The most common symptoms, you might hear the word vasomotor symptoms. That usually means hot flashes and also the night sweats that Dr. Jackson was just mentioning. So they are the most common and they affect up to 80% of people who go through menopause and perimenopause. And they can last for many years, unfortunately, also heard about how long these symptoms can last for some people and the risk factors that are different. Um, so they can disrupt, again, sleep, mood, and general quality of life. Other common experiences are the sleep disruptions, the changing and bleeding patterns, especially during perimenopause, which you'll hear some more about in a minute, where your bleeding can be normal and then it can start to get more irregular, but you could still be having all of these symptoms even when you're not in menopause yet. So there are all of those and just daily functioning, brain fog, lack of energy, things we don't even think about sometimes too, like hair shedding more and brittle nails. All of that, when people really think that they're sort of losing their minds, is really kind of normal with these hormonal changes. But again, we do have ways to help. So some common relief options would be hormone therapy, which is the most effective for vasomotor symptoms, especially of course, if somebody's okay to take them, and we'll get way more into that in a minute. And then there's also non-hormonal options that are also prescriptions and evidence-based behavioral interventions such as the CBTI that was just discussed.
Okay. All right. Thanks for taking us through that. All right, Dr. Faye, we'll turn back to you now. All right. Up next, let's see here. This person says, how do I know if I'm in perimenopause or menopause, especially if my periods are irregular or stopped?
So perimenopause is the transition phase leading up to menopause, and it can last several years. One of the most common signs is a change in the menstrual cycle. Periods may become shorter or longer, heavier or lighter, or you may start skipping your periods altogether. So I have this all written down because obviously it can be very complicated. But during this time is when you start noticing all the symptoms. So, such as the hot flashes, the night sweats, we've just talked about, the mood swings, the irritability, the trouble sleeping, the breast tenderness, the change in libido, vaginal dryness, weight gain, or changes in hair texture, with Kara just talked about. If you're unsure of what stage you're in, or the symptoms are affecting your quality of life, that's when it's a good time to start talking to somebody because it's hard to know. So that's when you talk to your healthcare provider. They can help you sort out what's happening and discuss treatment options. Menopause itself is defined simply as 1 year from your last menstrual period. And it's one full year, but the symptoms can start long before. So we can have these symptoms long before you have anything. And the symptoms are usually worse when your periods are erratic, heavier, lighter, longer, shorter, and everything else. Irregular or changing periods are often a sign that you're in perimenopause, and it's normal to experience a mix of symptoms during that time, and the symptoms occur then postmenopausally. So your perimenopause for when your periods are irregular, your postmenopause after you've had that 1 year of menopause, and we hope to spend a third of our lifetime postmenopause.
All right, thank you. Okay, before we move on to the next question here, just a plug, I see some questions being submitted into the Q&A. Thank you, keep them coming, and we will get to your live questions at the end once we get through these submitted questions. All right, next up here, Dr. Jackson. How long do menopause symptoms typically last? And I know we've touched on this a little bit, but can you talk about, do they ever fully stop?
Yeah. So I would break menopause symptoms up into like two big categories. So first we have the vasomotor symptoms, which have been discussed, which are typically hot flashes and night sweats. And those are the ones, like Dr. Faye said, last for an average of about 7 to 8 years. But for about a third of women, they'll have moderate to severe symptoms for more than 10 years. Having said that, for most people, the vasomotor symptoms will eventually resolve completely. The other group of symptoms is what we call the genitourinary syndrome of menopause. And that's going to include vaginal dryness, painful sex, and urinary symptoms. Those symptoms, without treatment, don't resolve and, in fact, tend to get worse over time.
Okay. All right, thank you. Okay, moving along here. Kara, I know you mentioned hot flashes and night sweats. Can you talk about what are the best treatments for those, especially, when they're happening at night?
Mm-hmm. So yeah, I mentioned very briefly, but so hormone therapy, you might see HT hormone therapy, or you might see people, because I know there's a lot on the internet, lots of different terminology. So you might see HRT, hormone replacement therapy going around as a term too. So that is shown to be the most effective treatment for hot flashes and night sweats when it's a safe option. And there are some people who cannot use those options, but it's a lot less people than we thought for a long time. So there's a lot less people who are, we'd say, really like the risk outweigh the benefits. So it's always a good thing to have a conversation about. So So if someone cannot use hormone replacement therapy or prefers not to, there are FDA approved non-hormonal options. So that includes paroxetine 7.5 milligrams daily, which is actually an antidepressant, like a pretty low level. So that can help some of the other mood symptoms as well, for some people. And then fezolinetant, 45 milligrams daily is the other non-hormonal option that's approved by the FDA. There are other things like gabapentin, oxybutynin, and other SSRIs and SNRIs, which are also a class of antidepressants that can also be used for these reasons. So the nighttime symptoms specifically often lead, like we heard about, to worse sleep, insomnia. Waking up at 2 a.m. is something I hear a lot. People all of a sudden are like, why? Why is it 2 a.m.? So treating those symptoms, including hot flashes and night sweats that might be leading to them directly, is the best way to do that. And gabapentin is commonly used at night because it can help with sleep as well as the general symptoms. And I won't go into this because it was very well explained, but the evidence-based behavioral options include the cognitive behavioral therapy, and also, interestingly, clinical hypnosis, which I was not expecting to hear that there wasn't evidence for something as common as acupuncture, but there was for clinical hypnosis. So you never know.
Yeah. Interesting. Okay. Well, thank you. Okay, Dr. Fay, we'll turn to you for this next question. What non-hormonal options are available for managing menopause symptoms?
So we've already gone into the hot flashes and the night sweats. So just to add a little bit more, we do have a newer non-hormonal that's also, we have the neurokinin 3 receptors. So we have another one that has already just been introduced. So we now have two that are non-hormonal. So we have two that are now for hot flashes and night sweats. And also just to add up to with Kara, as she talked about, there are certain antidepressants that we use now for as antidepressants for help with hot flashes. For the behavioral and lifestyle, we talked about also that can help with just overall. We also talk about for sleep, that has already also just been talked about. So the gabapentin, we have over the counter, magnesium. Sometimes people use melatonin. We also use some trazodone, which is also another sleep aid that can be used. So that's not over the counter, but that can be prescribed for and then for vaginal dryness, we have non-hormonal options that we use for vaginal dryness. If people don't want to use estrogen, we use things like hyaluronic acid, we use aloe, we use olive oil. And for lubricants, we use silicone and we use and pelvic floor physical therapy. For additional symptoms such as brain fog, libido, and joint pain, for brain fog and menopause, we also talk about if you improve the sleep quality of a patient, if you treat their hot flashes and you encourage regular exercise and you maintain social connection, you can help with their brain fog. For low libido, we talk about sex counseling, we talk about mindfulness, we talk about addressing their pain and vaginal dryness, and sometimes just encouraging relationship issues. So again, as a sexual counselor, we talk about therapy for that. For joint pain and bone symptoms, we talk about improving with exercise and movement. I always talk about calcium and vitamin D to making sure, because one of the big things when someone goes through menopause, the first 5 years, you can lose 20% of your bone. So we always encourage everybody, calcium, vitamin D, maintaining weight-bearing exercises and core strengthening exercises, and yoga and Tai Chi. So those are also things that we talk about that are non-hormonal methods for maintaining health.
Okay. All right. Thank you. A lot of great options. Appreciate you walking us through that. Okay, Dr. Jackson, now let's talk a little bit about hormone therapy. So, can you tell us the difference between traditional hormone therapy and bioidentical hormone therapy? And when is the best time to start?
Okay, let's start with the term bioidentical hormone therapy. I want you to know that this was really a term invented by marketers. It's usually used to refer to hormones that are chemically identical to those that were produced by the ovaries before menopause. There are FDA-approved bioidentical hormones, and that can include estradiol, which is a common version of estrogen that we use. It comes as a pill, a patch, a gel, and a spray that are used on the skin, as well as in vaginal formulations, in a cream, a vaginal tablet, and a vaginal ring. And then for progesterone, there is an oral micronized progesterone, which is also considered bioidentical. There are also compounded bioidentical hormones. These are often given as pellets. The problem with these is they are not regulated in any way. Unfortunately, there have been lots of studies to show that they have inconsistent dosing, they have no safety data, and they can't be removed. So these compounded hormone pellets are not recommended by the Menopause Society, nor by ACOG, which is the American College of Obstetrics and Gynecology. While these bioidentical hormone formulations are the most commonly prescribed right now, historically there were other formulations of estrogen and progestogen. And in the WHI study specifically, which was a big study in the early 2000s that looked at hormone therapy, they used a formulation called Prempro, which is an oral medicine that's a combination of Premarin and Provera. And you can see lots of different synthetic estrogens and progestogens. There's nothing necessarily wrong with them, but that would be the difference between bioidentical hormones and hormones that were used historically. As far as the other part of the question, when is the best time to start? The safest time to start hormone therapy is within 10 years of somebody's final menstrual period and before they turn 60. And that's when the benefits outweigh the risks for most people. People can start when they start having symptoms. They don't have to wait. I've had patients tell me, somebody told me I had to wait till I was fully menopausal before I could take menopause hormone therapy. You can certainly start in perimenopause. And sometimes there's different hormone formulations that we like to use in perimenopause. But as soon as somebody is bothered by symptoms, they can start.
All right. Well, thank you. And again, I think it's just really helpful to hear all the options that are out there. So thank you. Okay, Kara, we'll turn to you. Do people without a uterus need progesterone? And how does menopause differ after a hysterectomy?
Yeah, so if someone does not have a uterus, they don't need progesterone. So the main reason that we would prescribe progesterone for someone who is taking estrogen therapy is because if someone has a uterus, the lining of the uterus with the estrogen and no progesterone kind of working against it can build up and build up. And that can predispose people to issues like uterine cancer. So it's really important if somebody has a uterus and they are on estrogen therapy that we also do progesterone. So that's the primary reason that people use it. That's not to say that someone without a uterus can't have progesterone because it does have some benefits as well. And one of those is that it does help some people with sleep. So the micronized progesterone that was just mentioned can be taken about 30 minutes before going to sleep, and that does help a lot of people. Um, if somebody goes through a hysterectomy and their ovaries are removed at that time, that will be referred to as surgical menopause. So we know that their cycles are going to stop and that they are going to be done with their cycles quickly. Menopause symptoms are usually more abrupt and severe at that time. And I know I've heard a lot of stories, even talking to my mom about this and her friends who have kind of gone through all of this like silently. And I'm so glad that we're here talking about it now so that there is somewhere to turn. But yeah, people can be going through that and feel the side effects come on hard and strong. If ovaries are remaining, then it can be a little hard to tell when someone is perimenopause or menopause because they wouldn't be having their cycles, but the menopause itself would occur naturally. So, what that means is that although the hormone changes might be less predictable without the menstrual cycles, it's still going to be that over time they're going to have those ovaries kind of stop functioning the same way instead of abruptly all at once.
Okay. All right, thank you. Okay, Dr. Fay, going back to you here, I know you mentioned a little bit about, you touched on libido earlier. I'd like to dive into it a little bit more here. So can you talk to us about how menopause affects libido, orgasm, or sexual satisfaction, and what treatments are available?
Menopause affects all aspects of sexual function. Estrogen and testosterone both play roles in helping the brain feel interested in sex and responsive to pleasure. After menopause, many women notice less of an interest in sex, fewer sexual thoughts or fantasies, and more difficulty becoming aroused, and orgasms feel weaker or harder to achieve. We do have medication options available after menopause. And recently, surprise, surprise, with this new FDA, they've actually approved flibanserin, which is also known as Addyi, for use in postmenopausal women up to the age of 64. It's often referred to as the little pink pill, but the insurance coverage can still be a challenge. And it's been approved actually in the last month. And I've noticed right now that the insurance companies haven't realized that it actually has been approved yet for those women who are postmenopausal. And it's something that women can discuss with their providers to see if they're a candidate. We also sometimes use testosterone off label, and unfortunately it has to be paid out of pocket by women in carefully selected women. And I always emphasize that there's no condition called low testosterone in women. We do not recognize low libido based on testosterone levels. We only check a baseline for safety so that we don't raise your testosterone level too high when we're using the testosterone, because testosterone testing in women is not very accurate. Menopause also changes your vaginal tissues. They become thinner, drier, and less elastic. And many women experience dryness, burning, irritation, or pain with intercourse. And sometimes just as simply as using vaginal estrogen along with lubricants can sometimes, and pelvic therapy again, can also sometimes give a significant difference in terms of how someone feels. So, and sometimes dermatologic conditions are sleep disruption, again, being tired and can easily make it so that you just don't want anybody coming near you, or untreated hot flashes are the real contributors to low desire. So treating these issues alone can dramatically improve sexual function. Midlife also brings stress, right? With relationships, with caregiving, with body image and life transitions, all can affect desire and enjoyment. So open communication with our partners, counseling, sex therapy again, underlying and understanding that desire in midlife, this is so important, is now responsive. It's not spontaneous. We're not 22 anymore. We don't see that sexy guy and all of a sudden go, oh my God, he's so sexy. Remember, it's responsive. It's not spontaneous. And these changes are normal. You're not the only one. It's not your fault. And there are treatable conditions for this. So you need to talk to your provider or ask for help, because there are things that we can do.
Okay. Again, just knowing that there's options.
Absolutely.
All right, Dr. Jackson, we'll turn back to you now. I know, this conversation, we've been touching on a lot of different facets. We touched on brain fog. Can you kind of just dive into this a little bit more with us? How does menopause contribute to brain fog, fatigue, or memory problems?
Yeah, we know a lot about what estrogen and progesterone do for our bodies, but I think that they do even more than we ever knew. And there are estrogen and progesterone receptors in our brains, and they affect the neurotransmitters in our brains differently. So, especially in perimenopause, when the estrogen and progesterone levels are fluctuating, it can cause all sorts of symptoms. And this is when people tend to have the most mood changes, brain fog, and fatigue. Brain fog is sort of a vague word, although more than half of people in perimenopause will report some degree of brain fog. Most commonly, they have difficulty remembering words, names, sometimes an inability to focus. Fatigue can be a symptom in and of itself, and often it's also a consequence of other menopausal symptoms like night sweats and insomnia. The good news is these symptoms do tend to get better once people are fully menopausal. They're most pronounced in perimenopause with the fluctuating hormone levels. Hormone therapy is not approved to treat these symptoms specifically, although they're often accompanied by vasomotor symptoms, which we commonly use hormone therapy for. And sometimes off-label, we'll use hormone therapy just to treat these symptoms, because we know that by stabilizing the estrogen and progesterone levels, we can help some of these brain symptoms that are related to perimenopause.
Okay. All right. Thank you. Okay. This next question here, Kara, I'm going to turn to you. I know supplements are always a big topic. So can you talk to us about, are supplements or maybe lifestyle changes effective for menopause symptoms, and maybe which ones are evidence-based?
Thank you. Yeah, that is a really big topic, and I think people ask us a lot about things, and a lot of times I just have to say, like, we don't have a lot of evidence on it. There are a couple things that I'll mention that we do have evidence on or know are not as safe, or might help, but many things, because they're not kind of approved by the FDA, because they're not going through kind of the rigorous processes, the same as when we talk about the compounding pharmacies and how it's just not regulated in the same way. Unfortunately, you don't always even know what you're going to get. And then we also know that there are all sorts of cultural reasons, things passed down in families that are important, that people feel good about, and that isn't causing them any harm. And if it's not causing harm and you can know that and feel safe with it, then it is really something that I think is up to each individual. But I will mention what we do know. So, evidence-based behavioral interventions, we talked a lot about CBT and hypnosis for reducing the impacts of hot flashes. Both of them should be led by a certified medical provider or therapist, though, when you're looking into that. And I know that this is hard too. Like, we're already talking about stressors of midlife and finding time and what does insurance cover and access and childcare. So we know that when we say these things, it's not like, okay, this is so easy, you can just go figure it all out now. But it's about sort of what does fit into your life, what is your priority, and what can you make work. And like, maybe it's a time, and it's hard for a lot of us, socialized as women, to ask for help. But if you have a support system, then it might be a time to call them in and realize this isn't a forever thing. And you can do these things and make time for these things if possible, and it will overall get you to a better place. So other lifestyle changes like relaxation and taking big slow breaths, they can help with general mental health and well-being, but they were not actually found to reduce hot flashes or night sweats. So supplements like black cohosh, wild yam, dong quai, and even primrose are not recommended. There's just not enough research on them, and they can cause some health and safety concerns.
Okay. All right. Well, thank you. I think it's important to kind of do your research before. So appreciate you talking us through that. All right. Dr. Faye, we will turn to you now. Just a few more questions here until we get to our live questions, as I know you all have been submitting them throughout our discussion. So thank you. Okay. Dr. Faye, how does menopause affect more long-term health risks? So when we're thinking about heart disease, cholesterol changes, osteoporosis, I know you mentioned bone loss earlier. So can you just talk to us about that effect as well?
So before menopause, women have a much lower risk of heart disease. Estrogen keeps the blood vessels flexible, reduces inflammation, improves your cholesterol handling in the body. After menopause, our blood vessels become stiffer, blood pressure often rises, blood sugar control can worsen, weight tends to shift towards the abdomen. Everybody always notices that, right? And these changes increase cardiovascular risk. This is why the risk of heart attack and stroke begin to rise in the 50s and 60s, and women who have always in women who've always been healthy. So that's what helps regular exercise, not smoking, eating a healthy diet such as the Mediterranean diet can help, and managing blood pressure, cholesterol, and blood sugar. So in some women, starting hormone therapy around the time of menopause can help reduce our heart risk, but this has to be very individualized. Cholesterol levels often worsen around menopause. LDL tends to rise, HDL may go down, and triglycerides can increase, even in women who previously had normal levels. And this happens because estrogen, again, affects how these processes happen. Blood loss, as I said, bone loss, I'm sorry, also accelerates after menopause. And again, as I said, in the first 5 years, you can lose 20% of your bone. So osteoporosis, again, is very common in postmenopausal women. 5 out of 6 Caucasian women, Asian women can lose 20% of their bone and can be osteoporotic. So weight-bearing exercises, calcium-enriched foods, vitamin D, avoid smoking, heavy alcohol use, and bone density screening are all critical. And hormone therapy, again, has been shown to decrease the risk of hip fractures. Menopause doesn't cause heart disease. It doesn't cause osteoporosis overnight, but it does remove that layer of protection. So that's why midlife is such an important time. And even before that, to maintain a healthy diet, to make sure you're doing calcium and vitamin D, and to maintain your healthy eating habits, your exercise, and to also to think about what you're doing in your life.
Okay. All right. Thank you. All right. Just two more questions here, and then we'll hop to our live questions. Dr. Jackson, how does menopause affect urinary health, including urgency, incontinence, or vaginal dryness, and what can help?
I think Dr. Fay touched on this a little bit, but the lack of estrogen in the vulva, vagina, bladder, and urethra can cause a host of symptoms, which we call the genitourinary syndrome of menopause. This can cause vaginal dryness, pain with sex, burning or pain with urination, increased urinary frequency or urgency, urinary incontinence, and increased risk of urinary tract infections. As far as what helps, local vaginal estrogen can help. This can be given as a cream used vaginally, a tablet used vaginally, or a ring. There's also a vaginal DHEA suppository. DHEA is converted to estrogen in the vaginal tissue. And there's an oral medicine that's called a SERM, which is a selective estrogen receptor modulator that affects estrogen levels in different parts of the body differently, that can be taken to increase the estrogen levels in the vagina. Additionally, there's over-the-counter products that she had mentioned, such as vaginal moisturizers and lubricants for sex, and of course, pelvic floor physical therapy. All can help.
Okay. All right. Thank you. Okay. Well, with that, I want to go ahead and just hop to our live questions as you all have been submitting them. So how it'll work, I'll just read through the questions. Whoever wants to jump in, feel free. And this is definitely meant to be an open discussion. So yeah, let's get started. And thank you all for being so attentive and submitting such great questions. So, okay, to kick us off with this first question here. Is it normal in menopause to experience cramping as if you're getting a period but still not experiencing bleeding? Any thoughts? Kara, I see you nodding your head.
I've heard that for people, yes. That people can feel like they're cycling, they can have some cramping, and then periods don't really come on. It's something that I've also seen a lot in the family planning world of like certain birth controls and things people can be on where they're not having bleeding, but they're still feeling like that cramping. They still feel sort of a cycle, like a cycling in their body and different fluctuations. So it's variable, but it can happen.
All right. Thank you. Okay. Next question, getting through these. Can diet affect hot flashes? Are there specific foods known to help or worsen?
There's certain foods that are called phytoestrogens. So there's certain foods that people can take that are going to be possibly similar to an estrogen. We talk about soy, that might actually help. Um, so therefore, possibly, we talk about like edamame and things like that. Apples have some, so there are certain foods that might help, but you have to eat an awful lot in
Yes.
order to help. So, and that's probably why certain cultures have less hot flashes and night sweats than other people, so that their main symptoms are not hot flashes and night sweats, because their diets have always been more in the phytoestrogen.
All right. Thank you. Okay. This one's on hair shedding, which I know we kind of touched on a little bit earlier. This person says, are there ways to treat menopause related hair shedding? And would it be helpful to talk to a dermatologist who might be able to provide additional direction? Any thoughts?
So it might be helpful to talk to a dermatologist, and you want to kind of rule out other things that could be affecting, leading to hair loss, making sure that's kind of true of all these symptoms, making sure we're not just jumping to, okay, menopause is wreaking a lot of havoc in a lot of our bodies, but it's not the only thing that can be happening.
Right. Make sure there's not thyroid and things like that.
Exactly, which is something that, like, if you do go to a menopause provider, I think any of us would be running those tests as well. And then things like, again, this is we don't use hormone replacement therapy on paper for things like that, but I will say anecdotally, when we use it for vasomotor symptoms and other things, people seem to have less shedding of their hair if it is related to hormonal fluctuations.
Okay.
Sometimes too, the other thing about hair loss is for some people, they just have higher hair turnover with hormone fluctuations. So they're losing a lot of hair, but also growing a lot of hair. So really to think about if they have less hair on their head over time, or if they're just seeing more come out in the shower and the brush.
I'm
Mm.
learning a lot. Thank you.
Same. I always am. Okay, thank you. Very helpful. All right. Next question here. Can hormone therapy help with menopause weight gain?
No, menopause hormone therapy is weight neutral. The only thing that it has been shown is that if you're fatigued and you're not sleeping well, and therefore your activity level is diminished, and if you're sleeping well, then you're going to increase your activity. But hormone therapy is not a weight loss. But it has been shown to be effective with the GLP-1s to help increase somebody's weight loss if they're already on a GLP-1, but it is not a weight loss drug.
Although there are people who will say that they feel so much better on their hormones that they find it
Right.
easier to lose weight. But like Dr.
That's
Singh said,
because of
the
the,
hormones itself won't cause any weight loss. They also won't cause weight gain. I have some people who are afraid that they're going to gain weight if they start menopausal hormone therapy, and that's also not true.
right, it's a weight neutral drug, right?
Yep.
All right. Thank you. Okay. Um, this person says, can you address the gastrointestinal issues in menopause?
Like what? I'm not sure.
Any thoughts around gastrointestinal issues? Otherwise, I can move to the next question.
Think probably they would want to see a GI doctor to address that. There's not really any GI issues I can think of that are directly related to menopause.
Yeah, we don't have GI slowing, or I mean, people obviously, if they had if they had, you know, more constipation or more, irritable bowel, it's not related directly to a menopausal issue.
Think to adjusting to some of the treatments for perimenopause and menopause, though, some people do feel like bloating, especially when they're adjusting the first couple of months.
Mm. Okay. Okay. This next question, talking a little bit about bone health. Do you recommend getting a baseline bone density scan for someone just starting menopause, especially if they have
Absolutely.
a family history of osteoporosis?
It doesn't matter whether they have family history or not. Everybody, when they go through menopause, should have a baseline bone density because you're going to lose bone. So you should have a baseline bone density, whether you have a family history or not. Absolutely.
There's also, and yes, and there are also cases of if somebody goes through what we call like premature menopause, early menopause, if somebody stops bleeding when they're younger and we can't find another reason for it, there are many things we would do, including hormone therapy becomes incredibly important for bone health and cardiac health and all the things we talked about. And you would also want a baseline bone density in that case.
Absolutely. Absolutely.
Okay, so get your bone test. Good to know.
Yeah, we don't wait until someone's 65, even though quote unquote insurance says that. We don't.
Okay. All right. Next question here. Are there any recommended treatments for dizziness experienced during menopause?
Again, I think it's something that would need to be worked up to see why somebody was dizzy. Some people will have a sensation of dizziness associated with their hot flash. But just dizziness, I would want to know a bit more and have
Is
a
it
thorough
like,
workup of.
right? Is it their glucose level? Is it, are they having hypoglycemia? Are they having low blood pressure? What are they having? What else is going on with that? Is it their ears? What is going on?
Yeah, treating the underlying cause.
Yeah.
Yeah. Yeah. Main takeaway, go talk to your doctor. Okay. Can you talk a little bit about the effect of menopause on mental health?
Hmm.
Big question.
Well, it can cause absolute anxiety. The other thing is that one of the progesterones that we use, which we love, which is our um, micronized progesterone, can sometimes increase anxiety. So as much as we love it, sometimes that can also increase it. So therefore, we sometimes have to use one of our other progestins because of the fact that sometimes like a third of the people absolutely cannot use it. And so that can sometimes be a problem. And we sometimes have to do something else instead of that micronized progestin because of the fact that it can sometimes actually increase somebody's anxiety.
Something that's been very fascinating to me and kind of horrifying also in my own experience is all the things we've been talking about, especially during perimenopause, which was mentioned when instead of like postmenopause, when you're still having the symptoms in the vagina and the urinary tract, when you're having like these fluctuating levels, for a lot of people, it can feel like you're a teenager again, but you're old enough to realize that you're acting really irrationally, but you're still doing it.
Mhm.
And that can be just like, what is happening with me? And you can be up and down, and it's really hard to control. And that also has to do with caregiving burden, with fatigue, with everything else we've been talking about. So it is actually a time also where a lot of people get diagnosed with things like ADHD, and like anxiety, depression, like other underlying things that we've been able to kind of mask and work through and be very like high functioning in the world for many of us. And everyone's like, you're doing great. And then you realize that you've really been working very hard to get there. So it can be a really good time to seek support, and know that it's not just like a problem with you. It is really, really common to have mood swings and or underlying stuff get more pronounced.
Plus the fact that when people come in and think that they're perimenopausal and they actually have PMDD. So remember the fact that not everybody is ready for hormone therapy, but they actually are now being diagnosed with PMDD and and that's the other thing that we wind up diagnosing.
Do you want to say what that means real quick, PMDD?
Yeah, for a premenstrual dysphoric disorder, that we have people who come in with severe PMS, right? And so they're actually having PMS and they're not yet ready for hormone therapy, right?
Yeah.
Well, at least not menopausal hormone therapy, but we could
Right,
maybe
right. For
call
birth
birth
control
control
pill,
pills
birth control
hormone
pills.
therapy for perimenopause.
Right, right. Absolutely, right?
Lots of
So
options.
lots of options out there, right?
Just gonna say, going back, there's always options.
There's always options and there's always help.
Yeah, yeah. Okay. All right. Thank you. Okay. Next question here. Can you talk about the recommended time frame to continue hormone therapy?
If you start it within that 10-year window and and with it, which is the safe zone that I think Dr. Jackson talked about, if you're staying within that, if you get and you are doing well, now the studies have shown that you can stay on it for life, which is great. So therefore, we used to say that you can only stay on it for that 5-year window, but now if you are doing well, you can stay on it for as long as you choose to stay on it. If you choose to go off of it, that's perfectly fine, but you can stay on it for a long time. Same thing with vaginal estrogen. Vaginal estrogen, somebody can actually start it after age 60 and can stay on it for life. And we talk about the fact that vaginal estrogen should really be in the water. So you can start it whenever and you can stay on it forever because of vaginal dryness and vaginal pain with intercourse. And also vaginal estrogen can decrease your risk of urinary tract infections, which we know that affects our older women population. So that's something that actually we can use also forever.
And anyone can have it as well. So it's
Mhm.
only acts locally. So because it only acts locally, it's not going to help with like any of the systemic stuff like hot flashes and night sweats. But it also means if somebody has a reason that they shouldn't have estrogen through their whole bodies, that increases their risk. That vaginal estrogen, it will not do that, and there's no label saying it will anymore. So.
That's right, right. Because now that we have gotten it off that black label, right?
Yep.
Right, which is terrific, right?
Okay. All right. Thank you. Okay. Next question here. Can fibroids cause problems in perimenopause or menopause if they're not removed? Interesting question.
mean, perimenopause, people can have irregular and abnormal bleeding, and fibroids can add to that. But overall, as people go through menopause, and especially after menopause, fibroids tend to shrink and not cause problems anymore.
Okay. All right. Okay, we're going to take a few more live questions. Thank you again, everyone, for submitting these amazing questions. I am learning a ton. And then we will wrap it up with one final question for the evening before we close for the evening. So just a few more live questions here. This person is asking, are there any signs that menopause symptoms are coming to an end?
Things just get better. I don't think there's any like sign that you just start getting better. You just start having less hot flashes, night sweats. Um, no, I don't think there's any, you all of a sudden don't.
Yeah, and I think if somebody's not on any treatment, it would just be a
Yeah,
gradual decline.
yeah, yeah.
Okay. All right. Next question here. Can you talk about the impact of perimenopause, menopause on skin changes, such as skin
Mhm.
rashes, sensations? Any thoughts there?
I mean, I think everybody's an individual. I mean, some people, I mean, I guess the question is because some people are saying, should we use facial estrogen, right? And the answer is no, because people are saying, should we use vaginal estrogen on our face? And the answer is no, because of the fact that there really is no study out there that says that that's safe, because of the fact that then you go out in the sun and you can get melasma, which is the darkening of the skin. Also, the fact is that you're using a compound that the absorption of it can cause uterine cancer if you have a uterus because of the absorption of it, plus the fact that there really aren't studies out there that tell you that it's safe. Yes, we used to have something called esoterica, which maybe some of the older patients might realize, remember that your grandmother used to rub on her skin to make her skin nice and soft and everything else, which was estrogen. Okay, it was an old thing that was advertised when you watched some of the older shows. But the thing is that I don't think there's enough studies out there to show that we should be smearing estrogen on our face. Yes, we probably have smoother vaginas because of the estrogen smearing on our vaginas. But the thing is that I don't think that there's enough studies out there that say that we should be putting it on our faces at the vaginal estrogen dosage on our faces. But I think that you know, just in terms of things, I don't think there's enough documented studies, and I don't think there's going to be any studies right now that show that that should be done.
I have not had that question from anybody yet.
I
Specifically,
have.
specifically
I
that
have.
question. I was like, oh, is that what people are talking? Interesting.
Yes, people are
Okay,
talking
now
about it.
now I'll know. But and one other thing I wanted to bring up real quick, and I know we're short on time, is like collagen changes. Like people do see differences in their skin. People
Hmm.
can look in the mirror and feel like they don't really recognize themselves, and that can be really hard. So
Hmm.
some of it is just kind of like what is a normal change? How do things feel? And I think that whether or not, and at least personally for me, whether or not like actually look different, if I'm exercising, if I'm
Hydrating.
although well supported, yeah, hydrated, like those things, I feel like I look better, even if I look exactly the same. So I would encourage like kind of just things that make you feel better in your body that are
Right,
healthy things.
right, right.
That's a really great point. Okay. All right. Let's do one last live question and then we'll wrap it up. Can arthritis and sciatica pains be attributed to menopause?
We talk about joint pain, okay? And we talk about the fact that estrogen greases your joints. So there's a study that shows that there's something called the 50 shoulder, where if a woman goes and gets a shoulder surgery and she's on estrogen, she's going to do much better if she's on estrogen versus one who's not. And there's actually a lot of work now, thank God, from female orthopods that are showing that estrogen and joints are definitely related. But I don't think anything out there that's showing anything with osteoarthritis or anything like that. But there's definitely a lot of now push by female orthopods to try to convince women to go on estrogen. for joint health and musculoskeletal stuff. So it really does show a lot, but I don't think particular diseases out there. But definitely women will come in and say, my joints, I didn't realize my joints hurt, and now they don't hurt anymore. So estrogen really does a lot for greasing the joints. But particular diseases, I don't think so.
Okay. All right. Well, with that, I want to go ahead and ask my final question for this evening. So that is, what are your goals from everyone listening in on this webinar? And what would you like our viewers to take away from tonight? So Dr. Faye, why don't we go ahead and start with you?
Menopause isn't a disease. It's normal stage of life. We all go through it, and hopefully we all will live a long life. And there is real effects on your body, your health, your mind, your quality of life. And you don't have to suffer in silence. Your symptoms are real. They can affect your heart. They can affect your cholesterol. They can affect your bones, your sleep, your sexual health, your mental health. You have options for treatment. There is no single right choice for anyone, for everyone. You deserve to feel good. You deserve to have someone listen to you and work with you. Find the right person. Don't suffer.
Right. Thank you. Important closing remarks. Okay, Dr. Jackson.
I think it's great that there's so much talk right now about perimenopause and menopause. There's tons of information available. Unfortunately, there's also plenty of misinformation available. So just be careful with what you're reading. Be skeptical of anyone trying to sell you something. And remember that everyone's experience with perimenopause and menopause is unique. Talk to your doctor. And if your doctor's not comfortable talking about it, find a doctor who is comfortable talking about it. Talk about your symptoms, your personal health history, your personal goals, and find a treatment that's best for you.
Okay. Thank you. That self-advocacy piece is really important. So thanks for bringing that up. All right. And last but not least, Kara, any final remarks?
Thank you. I want to reflect and amplify what both of the doctors have said. I agree. My main takeaway was going to really be find community. Don't let this isolate you, and definitely find a provider that will listen to you. There are a list of us on the Menopause Society site, but I also will say, like, look for someone who's not just certified, but is like seeing you as an individual. Most people going through menopause identify as women. Not all people going through menopause identify as women. So going somewhere where you're not going to feel stigmatized, where you're going to feel seen and heard, no matter what your situation is, what your financial situation is, whatever you're going through, that you can be respected as an individual, that we are not supposed to be gatekeepers in medicine. And whether that's advanced practice provider, a midwife, a doctor, like find someone certified and knowledgeable who also is willing to work with you. And if they don't know something that will help you, that they're going to look it up and talk to people and make sure that you feel supported.
Okay. All right. Well, thank you all, Dr. Faye, Dr. Jackson, Kara, for your time this evening. Such great information was shared. And a big thank you to you all for taking the time to attend, submit your questions. You all took this big first step toward being that best self-advocate. So thank you. We will be posting an event survey, so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. A recording of this event will be sent to you, so you can rewatch at your convenience. And if there's anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.